Hi everyone, welcome to Unit 2 on the Respiratory Disorders for NURS 2020 Advanced Pathophysiology and Microbiology. Here's the content of today's lesson. We'll start off by looking at the various classical clinical manifestations for respiratory disorders, and then we'll go through all these other disorders related to both the upper and lower respiratory tract. Please remember to read this particular slide deck as well as all the other learning resources that are posted on the Blackboard shell. Let's first look at the different types of respiratory pattern. So from A and P, you'll remember this is tidal breathing, which is about 500 mils in and out. During inhalation, 500 mil goes in, and then you exhale 500 mil, and the breathing rate is around 12 breaths per minute. In obstructive disorders such as asthma and COPD, as we'll see, you have prolonged expiration. So inhalation seems to be fine, but exhalation takes a longer period of time. In bradypnea, you can see the breathing rate has slowed down, and the opposite would be tachypnea, where the breathing rate has increased. Cowsmell's breathing is a fast and deep type of breathing, you can see, so it's probably more than 500 mils and much more rapid. That occurs, for example, in type 1 diabetics who have developed diabetic ketoacidosis, for example, which is a form of metabolic acidosis. In addition, when you exercise, naturally you produce more CO2, and CO2 is the main driver of respiration. You have to exhale out all that CO2, so your breathing becomes fast and deeper as well. The other type of breathing pattern that we'll examine is the Shine-Stokes breathing. Here you have a changing rate and depth of respiration along with apnea period where there's no breathing in this particular period of time. That's quite ominous. That occurs, for example, in drug-induced respiratory depression, for example, overdose with opioids, as well as in brain damage, especially when the brainstem and the respiratory centers in the brainstem are damaged. It can also occur in congestive heart failure and uremia from acute as well as end-stage renal failure. So that's acute renal failure, acute kidney injury, and end-stage renal failure. Just remind you from A&P, the respiratory rate is determined mainly by CO2. So normal arterial CO2 is approximately 40 millimeters of mercury, and breathing rate increases as PCO2 increases, as you can see, quite dramatically. On the other hand, oxygen levels, in this case PO2, doesn't really affect the breathing rate until PO2 drops below 60. And when PO2 drops below 60, remember normal PO2 is 95 to 100. Here, when PO2 drops below 60, that's when breathing rate and depth increases. Under normal condition, its breathing rate and depth is all determined by CO2. It's the main driver of respiration. Let's look at a couple more clinical manifestations. So what can cause acute dyspnea? It's not just pulmonary disorders, as you might anticipate, and we'll certainly go through all of these, but it can also be cardiac in nature as well as neurological in addition. So let's start off with the pulmonary causes of acute dyspnea or difficulty breathing. It could be upper airway obstruction, such as aspiration or croup we'll look at as well. Anaphylaxis will do when we do the immune system disorders, but that can cause significant constriction in the pharynx as well as larynx. So that's an upper airway obstruction that will definitely cause acute dyspnea. Various airway diseases that we'll examine shortly, such as in asthma and COPD, those are obstructive disorders, as well as in acute bronchitis. Various parenchymal lung diseases such as ARDS or acute respiratory distress syndrome, as well as pneumonia, which is an infection of the lower part of the respiratory tract. Various pulmonary vascular diseases such as pulmonary embolism, and various pleural diseases such as pneumothorax or tension pneumothorax. But it's not just pulmonary disorders that can cause acute dyspnea. There are various cardiac causes as well, such as in acute myocardial infarction, exacerbation of heart failure, cardiac tamponade, CAD, and various arrhythmias. So the point being, acute dyspnea is not just caused by pulmonary disorders. We also saw that neurological causes such as metabolic acidosis, whereby the respiratory centers are affected, can cause that Shine-Stokes breathing, for example, in acute dyspnea, but anxiety and panic attacks can also cause acute dyspnea. Chronic dyspnea, on the other hand, instead of hours to days, it lasts typically 4+ weeks, can have, just like in acute dyspnea, cardiac and pulmonary causes. Cardiac causes could be myocardial dysfunction, heart failure typically, or valvular heart disease. Pulmonary causes, typically the same as for acute dyspnea, could be COPD and asthma, which is obstructive lung disorders, parenchymal diseases, vascular diseases such as pulmonary hypertension. Pulmonary embolism, PE, would cause acute dyspnea, not chronic dyspnea, and pleural diseases. There are also various medications, and more importantly, severe anemia can cause chronic dyspnea as your body becomes short of oxygen over there. So we covered anemia when we did Unit 1. Hypothyroidism increases the metabolic rate in the body, and that can cause chronic dyspnea as well. Also, various neuromuscular and chest wall disorders such as obesity, whereby you impact the functioning of the diaphragm. Pregnancy, similar, whereby the expanding uterus impairs reduces the functioning of the diaphragm. Various neuromuscular diseases such as myasthenia gravis and ALS can also affect the functioning of the diaphragm, where you spoke about psychosomatic causes such as anxiety. What about chest pain? Chest pain is typically associated with cardiac causes, but it can also be pulmonary in nature. Firstly, we need to divide chest pain into pleuritic or non-pleuritic chest pain. That means that pleuritic chest pain is that the pain becomes worse upon breathing, typically during inhalation or exhalation less commonly. Non-pleuritic chest pain is that the chest pain is not associated with breathing. So as you can imagine, pleuritic chest pain we would immediately associate with something to do with the lungs, pulmonary in nature, and indeed pleuritic chest pain causes or etiology could be pneumonia, PE, various neoplasms, pneumothorax, TB, tuberculosis, and so forth. But there are also cardiac causes of pleuritic chest pain, such as pericarditis, and that's because the pericardium is in close proximity to the pleural lining. So as the pericardium moves, it can irritate the pleural lining and result in pleuritic chest pain. Their musculoskeletal disorders can also cause pleuritic chest pain, such as costochondritis, which is inflammation of the costal cartilages, and as the lung moves, it irritates or causes pain due to the inflammation of the cartilage as the cartilage moves, and that can cause pleuritic chest pain. Fractured ribs, typically several of them, can result in flail chest, and that can also result in pleuritic chest pain. There's also non-pleuritic chest pains, again pulmonary and cardiac in nature. So non-pleuritic chest pain caused by pulmonary causes could be pneumonia. So as you can see, pneumonia can cause either non-pleuritic chest pain or pleuritic chest pain depending upon the location of consolidation in the lung, and we'll discuss pneumonia shortly. PE is the same, could be pleuritic or non-pleuritic chest pain. Same thing with neoplasms. Cardiac causes of non-pleuritic chest pain is usually MI. So usually MI is not associated with pain that is related to the breathing. So in the case of MI, it's usually a non-pleuritic chest pain, retrosternal chest pain that might radiate to the left shoulder, left jaw, left arm. Myocarditis, usually non-pleuritic chest pain. Pericarditis could be pleuritic or non-pleuritic chest pain. In addition, for non-pleuritic chest pain, there are various esophageal causes that can cause it, such as GERD or gastroesophageal reflux disease that we'll discuss when we do the GI disorders. We're not going to go through all the other ones as well. Pain below the diaphragm or subdiaphragmatic chest pain can be caused by peptic ulcer disease. Also, we'll discuss that in gastritis and biliary colic and pancreatitis when we do the GI disorders. But sometimes, because of the fact that the abdominal region is not well innervated, it's hard to tell whether it's coming below the diaphragm or above the diaphragm, and it's usually just at the boundary, and sometimes it's just referred to as chest pain. The patient would describe it as chest pain. So for chest pain, again, we usually go immediately to either a cardiac cause or pulmonary cause, but it could also be these GI causes as well. Similarly, it could be a vascular cause caused by an aortic aneurysm or dissection of the aorta. We covered all this in Unit 1. And similarly, MSK disorders such as costochondritis that we saw previously, that could be pleuritic or non-pleuritic chest pain. and various rheumatic diseases such as rheumatoid arthritis. Anemia as well, and hypothyroidism, usually non-pleuritic chest pain rather than pleuritic chest pain. Let's move on to the next clinical manifestation of cough. What are the differential diagnoses of cough? So the ones listed in bold are the ones you should focus upon. Those are the most common ones over there, starting with GERD, which is not a pulmonary disorder, it's a GI disorder. But as the acid gets refluxed into the esophagus, that can cause irritation of the esophagus, resulting in a cough. So that's one of the main causes. You can see it has an asterisk over there. That's one of the big three causes of a chronic cough. The other one is upper respiratory tract infection, which we are far more familiar with, usually caused by a postnasal drip. So you have a cold or a whatever nasal congestion caused by some upper respiratory tract infection. It resolves, but then this postnasal drip occurs that it can cause this chronic cough over there. So acute cough, obviously, during the course of the acute illness, and then a chronic cough due to this postnasal drip, or it could have spread and caused sinusitis. Asthma can cause this chronic cough as well, chronic asthma. So anyways, the couple of more common causes of cough include inhaled irritant, postnasal drip, as we saw, aspiration, especially because of GERD. And then we have upper respiratory tract infection, acute and chronic bronchitis, very common. Asthma, COPD causes a chronic cough, very commonly as well. We'll discuss both asthma and COPD when we do the obstructive lung disorders. Various parenchymal diseases such as pneumonia that we'll be discussing, PE or pulmonary embolism, heart failure. We saw especially left-sided heart failure causes pulmonary congestion, and one of the hallmark clinical manifestation, the backward effects of left-sided heart failure is a cough. Drug-induced, these ACE inhibitors, especially in East Asians and South Asians, can cause a cough over there. These ACE inhibitors that are used very commonly to treat hypertension, as well as for various other indications as well. So that's why if you're a South Asian or East Asian, it's not recommended to be given these ACE inhibitors. Much rather swap out the ACE inhibitors for an ARB or angiotensin receptor blocker. In terms of the effects, they're exactly the same. Mechanisms, obviously, they're different, but the effects are the same. And so ARBs don't cause a chronic cough like the ACE inhibitors. And obviously smoking, that's obviously naturally related to the obstructive lung disorders. So here's just a differential diagnosis of cough. Hemoptysis is another clinical manifestation associated with the respiratory disorders. So what are the common causes of hemoptysis, of coughing up of blood? It could be acute or chronic bronchitis, acute bronchitis due to an infection, chronic bronchitis due to COPD, various parenchymal diseases such as pneumonia, TB especially, various vascular diseases such as pulmonary embolism, and miscellaneous causes as well. So we're going to focus upon acute and chronic bronchitis, especially in the context of COPD, cystic fibrosis. We'll discuss pneumonia, TB, and primary lung cancers, pulmonary embolisms, and that's pretty much about it. So we'll start off by looking at the specific pulmonary disorders. So here are the pulmonary disorders. It could be related to the chest wall. We're not going to really focus upon it except for pleural effusion. But obesity is also considered a pulmonary disorder because it affects the movement of the chest wall by interfering with the functioning of the diaphragm. We'll focus instead upon the disorders related to the airways, so obstructive lung disorders, for example, such as asthma and COPD and cystic fibrosis. We're not really going to focus upon restrictive lung disorders because there's really no cure for that other than a lung transplant, so we'll kind of ignore mostly the restrictive lung disorders. The most characteristic restrictive lung disorders are idiopathic pulmonary fibrosis, etiology unknown, probably autoimmune, and only treatment is a lung transplant. And then we'll also look at vascular disorders related to the pulmonary disorders, such as pulmonary embolism that causes increased vascular resistance. So that's PE is a thromboembolic disease. There are also pulmonary disorders related to the respiratory control and infection, as well as trauma. So we'll examine all of these, probably not sleep apnea, which you'll cover in the other nursing courses, but we'll examine various infections of the lungs, such as pneumonia. We'll look at pneumothorax and then all these disorders, especially focusing upon the obstructive lung disorders and PE as well. I just want to make a mention as a refresher for E&P about this ventilation perfusion mismatch over here. So under normal condition, you have blood flowing into the lungs. Here's a pulmonary capillary that blood flows in through the venous system, whereby PO2 is 40 and PCO2 is 45. In the alveoli, PO2 is 100, so oxygen automatically diffuses from the alveoli into the blood in the pulmonary capillaries over there because of this gradient, oxygen gradient. Remember, everything flows down their concentration gradient, and we measure the concentration gradient of gases by measuring their PO2. So it's high in the alveoli for oxygen compared in the pulmonary arteries over there. So oxygen diffuses from the alveoli into the pulmonary capillaries over here. CO2, on the other hand, is 45 in the pulmonary arteries and the pulmonary capillaries, and CO2 is 40. It's not 0 in the alveoli because of this incomplete mixing. You don't exhale out everything, otherwise your lungs would collapse. So because of the incomplete mixing, there's still some CO2 in the alveoli. Nevertheless, CO2 diffuses from the pulmonary capillaries into the alveoli. So that's the normal ventilation perfusion matching. You have to have proper ventilation to bring in fresh air into the alveoli, and you have to have proper perfusion. Now that can get altered, and there can be disorders related to ventilation perfusion. So if it's not properly matched, you can get mismatches of ventilation and perfusion. So for example, if you have a disorder in the ventilation, if you have an obstruction in the upper respiratory tract, now air is no longer able to enter into the alveoli, and so now you have a ventilation perfusion mismatch. Perfusion is fine, but there's no ventilation, and so now you have a shunt. So blood comes in through the pulmonary arteries into the pulmonary capillaries, but nothing happened, and it just goes out into the pulmonary veins. That's what we call a shunt, because nothing's occurring over here. The blood is just shunted right through that area of the lung that is not being ventilated. On the other hand, if you have an obstruction in the pulmonary vasculature, for example, because of a pulmonary embolism, now you have what's called a dead space. So ventilation might be fine, but diffusion doesn't occur because there's no blood flow. So this area of the lung is well ventilated, but it's not perfused because of the thrombus or embolus over here, like in the case of a pulmonary embolism, and so you have what's referred to as a dead space over there. In both these cases, in the case of a shunt as well as in the case of a dead space, you have a ventilation perfusion mismatch. It's V over Q, where V is a ventilation, Q is perfusion. Here, because ventilation is decreased, you have a decreasing V over Q ratio. The A stands for the arterial blood flow into the lungs. Here's normal. VQ ratio is what it should be. Doesn't matter what the numbers are. And over here you have an increasing VQ ratio because ventilation is fine, but perfusion has decreased over here. What are the etiologies of hypoventilation? They include COPD and asthma. As obstructive lung disorders, we'll be discussing that. Central respiratory drive depression caused by drugs such as the narcotics, morphine, fentanyl, as well as benzodiazepine and barbiturate. Various neurological disorders such as encephalitis, multiple sclerosis, and brainstem damage to the respiratory centers in the brainstem. All those can cause hypoventilation, as can obesity, because of the interference in the functioning of the diaphragm. That's similar to kyphoscoliosis as well. And lastly, severe hypothyroidism, whereby the entire metabolic rate in the body decreases significantly, including the breathing rate. What about the causes of hyperventilation or tachypnea? They could be a compensatory response to hypoxemia, or when you're exercising vigorously, that would be anticipated. Also, in acute exacerbations of COPD, that can cause hyperventilation. Usually COPD causes hypoventilation, but in this case it can also swing towards hyperventilation, especially in an acute exacerbation. A pulmonary embolism can cause hyperventilation and tachypnea. Heart failure and pulmonary edema can cause hyperventilation as well, and certainly dyspnea. Pneumonia and various other infections Any infections, especially bacterial infections that can cause a fever, will increase the breathing rate, will cause hyperventilation. Finally, drug overdoses with aspirin, cocaine, and amphetamines can also cause hyperventilation. Remember, the narcotic drugs cause hypoventilation, whereas aspirin can cause overdoses of aspirin can cause hyperventilation. Lastly, neurological disorders such as meningitis can also cause hyperventilation. That will be bacterial meningitis. Let's move on to discuss respiratory failure. Respiratory failure, the definition is when the respiratory system cannot maintain normal blood gas levels. That could mean hypoxemic respiratory failure, whereby PO2 in the arterial system drops below 60 millimeters of mercury, or hypocapnic respiratory failures, whereby CO2 builds up to over PCO2 of 50 millimeters of mercury. What are the clinical manifestations of respiratory failure, be they hypoxemic or hypocapnic? Those are the two forms. Well, it really depends upon what the underlying disease is. But generally speaking, in hypoxemic respiratory failure, you have the lack of oxygen delivery to the various organ systems in the blood, especially to the brain, resulting in restlessness, confusion, cyanosis in the peripheral tissues, all the way to a coma. In the case of hypocapnic respiratory failure, you have a buildup of CO2 that can result in a drop in pH, metabolic, and in this case, respiratory acidosis, and that can cause headaches, dyspnea, drowsiness, asterexis, peripheral vasodilation leading to warm peripheries, as well as the increased ICP that is also secondary to vasodilation in the cerebral vasculature. So how do you know whether it's hypoxemic or hypocapnic respiratory failure? Certainly you need to measure the ABGs or arterial blood gas values, take a chest x-ray in order to see what the underlying pulmonary disorders, for example, are, or perhaps a CT scan in order to determine what the underlying disease is, because you have to treat the underlying disease before you can treat the hypoxemic or hypocapnic respiratory failure. Let's examine hypoxemic respiratory failure in more detail. As mentioned previously, the definition of hypoxemic respiratory failure is when PaO2 has decreased, and in this particular case, we have to assume that PaCO2 is normal or perhaps slightly decreased because of hyperventilation. When PaO2 drops below 60 millimeters of mercury, we know that the breathing rate increases dramatically, and that can cause a decrease in CO2. But we'll focus upon the decrease in O2. The treatment for hypoxemic respiratory failure is, yes, oxygen therapy and other forms of hemodynamic support. The etiologies include high altitude, where there is a lack of oxygen in the air itself, and that even if your breathing is normal, that's going to cause a lack of diffusion of oxygen from the alveoli into the pulmonary blood vessels. So that will certainly cause a decrease in PaO2. So in individuals moving up to high altitude, when you climb Mount Everest, for example, the risk of developing hypoxemic respiratory failure is significantly increased, and that's why you need supplemental oxygen. Post-op as well, there's an increased risk of hypoxemic respiratory failure because of the low fractional inspired content of oxygen. Various drug overdoses, such as with the narcotics, that causes hypoventilation, and that's certainly going to lead to a decreased PO2 and leading to hypoxemic respiratory failure. Pneumonia and acute respiratory distress syndrome can also lead to hypoxemic respiratory failure, as can shock and COPD. What about hypocapnic respiratory failure, where you have a buildup of CO2 in the arterial blood supply, and hence PCO2 is increased? PaO2 is normally decreased because, as we know, when CO2 builds up, your breathing rate increases, and consequently, your PaO2 is also decreased as well. In that particular case, what is the pathogenesis of hypocapnic respiratory failure? In the case of hypocapnic respiratory failure, it could be several etiologies, including an increase in CO2 production. That can occur, for example, in fever when the metabolism in the body has increased greatly, or in sepsis, which is similar, or in seizures as well. So you have overall increased metabolic demands in the body, resulting in increased CO2 production. Another cause of hypocapnic respiratory failure could include hypoventilation. So here you have insufficient gas exchange despite a normal breathing rate of increased minute volume. So that can occur in the case of COPD, where you have mucus buildup. We'll discuss COPD in more detail later on, and asthma and cystic fibrosis. So you have obstructive lung disorders. All of them are obstructive lung disorders whereby you have inefficient gas exchange, especially in cystic fibrosis. Lastly, hypoventilation is the most common cause of hypocapnic respiratory failure. That can be caused by several different etiologies, including central causes such as a brainstem stroke that affects the respiratory center, where we spoke about the opioids and benzodiazepine that causes respiratory depression. Various neuromuscular causes, we've seen this previously, such as in myasthenia gravis, or injury to the phrenic nerve that controls the diaphragm, muscular dystrophy, kyphoscoliosis. All of these affect the proper functioning of the diaphragm. Lastly, for example, in acute exacerbation of asthma, and especially when it is a prolonged acute exacerbation, muscle fatigue can set in, muscle fatigue of the diaphragm and the accessory muscles of respiration. Those would be the intercostal muscles. All that muscle fatigue can ultimately lead to hypoventilation, resulting in an increased PaCO2. We'll now move on to the actual lung disorders, starting with the so-called mechanical lung disorders, and we'll start off with pneumothorax. Pneumothorax, pneumo is air and thorax is the thoracic cavity. Pneumothorax, the definition is the presence of air in the pleural space. For A&P, we have to remember that in the pleural space we have a negative pressure, negative relative to the pressure in the lungs, and as soon as that negative pressure disappears, now the lungs will automatically collapse. So when you have pneumothorax, you have the entrance of excess air into the pleural space, and that will cause an increase in the pressure in the pleural cavity, thereby causing a decrease in the compliance of the lungs, resulting in a partial lung deflation. So as soon as air enters into the pleural space, this is the pathogenesis, it raises the interpleural pressure, which is usually negative, I mentioned, and immediately the lungs will partially deflate depending upon the extent of the pleural space that has been affected. So what is the etiology of pneumothorax? It could be traumatic. For example, if you have a penetrating or non-penetrating chest wall injury that allows entry of air into the pleural space. It could be iatrogenic. For example, in mechanical ventilation, that somehow damages the pleural lining, causing air to enter into the pleural space. Or it could be secondary to some underlying lung disease, for example, in pneumonia, lung cancer, and COPD. So what are the clinical manifestations of pneumothorax? If it is a small pneumothorax, it could be asymptomatic. If you assume that it is symptomatic, it could be pleuritic chest pain, dyspnea, tachypnea, as well as tachycardia, which are compensatory responses. As soon as air enters into the pleural space, you're going to have ipsilateral, usually it's only on one lung, diminished chest expansion because the lungs have partially collapsed on that side. Air in the pleural cavity can definitely result in hyperresonance when the nurse is assessing for it, as well as diminished breath sounds on the side of the lung, ipsilateral side of the lung, whereby air is entered into the pleural cavity. On the other lung, on the contralateral lung, that should be functioning normally. Tension pneumothorax is a medical emergency whereby a large volume of air is entered into the pleural space and it progressively accumulates, and that in turn can lead to hemodynamic instability. So it is a very severe form of pneumothorax. In pneumothorax, a small amount of air is entered into the pleural cavity. Here, a large amount of air that has progressively, so not just that it has entered, but it continues to enter into the pleural space. And the pathogenesis is a one-way valve-like opening into the pleural cavity. So air enters into the pleural cavity but cannot exit, and so air progressively accumulates in the pleural cavity. What are the clinical manifestations of tension pneumothorax? It is the same as for pneumothorax, except now because of the large volume of air in the pleural cavity that is progressively accumulating, you can now have a contralateral tracheal and mediastinal shift, and that results in hemodynamic instability. As the pressure increases in the thoracic cavity, you have a decreased venous return, preload has decreased, and that could lead to hemodynamic instability. Ultimately, cardiac output will decrease as well. If this is not treated, that can ultimately lead to respiratory failure and shock. And that's why it's classified as a medical emergency. Let's now discuss pleural effusion. Pleural effusion is when you have excess amounts of pleural fluid in the pleural cavity. Two types. Transudative is where you have an increase in the hydrostatic pressure in the pulmonary capillaries, and that could be because of heart failure. We'll discuss cirrhosis and nephrotic syndromes later on. So the increase in the hydrostatic pressure causes increased transudation of the fluid into the pleural cavity, resulting in a pleural effusion. Exudative pleural effusion is when you have increase in the permeability of the capillaries or lymphatic dysfunction. The lymphatic system in the lungs drains the excess fluid from the pleural cavity. The etiology could be an infectious cause, malignancy, pulmonary embolism, or generalized inflammation, for example, due to autoimmune disorders such as rheumatoid arthritis and systemic lupus erythematosus. So anything that causes serious inflammation in the body can ultimately result in exudative pleural effusion. What are the clinical manifestations of pleural effusion? Well, just like in the case of pneumothorax, it depends upon the size of the pleural effusion. Oftentimes it's asymptomatic, but if it is large enough, it can cause the following clinical manifestations, including dyspnea, and naturally the dyspnea will depend upon the exact size and of the pleural effusion as well as the underlying lung functioning. Pleural effusions can cause pleuritic chest pain as well as orthopnea. In terms of the assessment, you can see for percussion, there should be a decrease in the tactile fremitus and dullness to percussion. For auscultation, there should be decreased breath sounds or bronchial breathing, as well as potentially a pleural friction rub as well. So the treatment for pleural effusion, especially if it's large, would be thoracentesis, whereby you need to drain all the excess fluid from the pleural cavity and naturally also treat the underlying cause, be it a malignancy or whatever the actual cause is, because otherwise draining the fluid will only work temporarily and more fluid will build up. So you have to treat the underlying cause of the pleural effusion itself, which we saw on the previous slide. What about pulmonary embolisms? The definition of a pulmonary embolism, or PE, is a mechanical obstruction in the pulmonary vasculature that leads to the obstruction of blood flow. In terms of the etiology of the PE, DVTs, or deep vein thrombosis, as we saw in Unit 1, is the most common source of pulmonary embolism. Less common causes include fat emboli, septic emboli, thrombi, as well as an air emboli. But the most common cause for PE is DVT. The thrombi often start in the calf, but must propagate through the inferior vena cava to create a sufficiently large thrombus for the pulmonary embolism. So from the inferior vena cava, it goes into the right atrium and then on towards the pulmonary vasculature. If the thrombus moves through the other smaller veins, that's usually not going to cause a pulmonary embolism because the thrombi is not going to be very large. In terms of the epidemiology of a pulmonary embolism, it is one of the most common causes of preventable death in hospitals. So it is typically, occasionally, a iatrogenic cause. So what are the risk factors for the development of a pulmonary embolism? The number one risk factor is blood stasis. So any client patient that is immobilized because of paralysis, a stroke, they have to be on bed rest, a fracture, especially of the lower extremities, say the tibia or the femur. Anything that causes prolonged immobilization, including prolonged sitting on transcontinental planes, air travel, that can cause blood stasis, and that increases the risk of the development of a DVT, and ultimately the DVT can progress to a pulmonary embolism. Obesity and heart failure also causes blood stasis, thereby increasing the risk of pulmonary embolism, as does chronic venous insufficiency. That is also a risk factor for DVT. Anything that causes endothelial cell damage, for example, post-op or any significant trauma, that increases the risk of thrombi formation, as do the other hypercoagulable states, including in the case of disseminated cancer, when the cancer has metastasized, so various malignancies. The oral contraceptive pill and HRT also increase the risk of the development of thrombi. In the case of pregnancy, everything slows down, including the blood flow. That increases the risk of the development of DVT as well as PE, and as well as naturally a prior history of DVT or PE, as well as a family history. Lastly, age is a non-modifiable risk factor for the development of pulmonary embolisms. What are the clinical manifestations of a pulmonary embolism? Acute dyspnea, pleuritic chest pain, hemoptysis, tachypnea, cyanosis. All those are anticipated clinical manifestations of a pulmonary embolism. Occasionally there's a fever and hypoxia, as well as blood flow naturally through the lungs has been impaired. There's a ventilation perfusion mismatch, and a hypoxemia, which can progress to hypoxemic respiratory failure, can also develop over there. So please make sure that you focus upon the clinical manifestations, but the clues towards the development of a PE is to look at the risk factors that we saw. So a client that is post-op that suddenly develops pleuritic chest pain, acute dyspnea, and potentially hemoptysis, there should be a very high index of suspicion for pulmonary embolism. So you have to investigate, you have to ask about those prior risk factors that we described for the development of a pulmonary embolism, especially the modifiable risk factors. So here's the Wells criteria that is used to diagnose a PE. So if there are clinical signs for DVT that we looked at in Unit 1, for example, a warm calf, a calf that has increased in diameter compared to the other calf, so any clinical signs of DVT, that is the number one risk factor, as you can see, for the development of PE. And obviously, if you've ruled out other alternative diagnoses as well, in the case of the physician of that. Otherwise, you look at the risk factors. Is there a history of surgery or immobilization? Is there a history of previous PE or DVT? Is there tachycardia, hemoptysis, malignancy? Those, for hemoptysis and tachycardia, those are clinical manifestations, as would be the clinical manifestations of DVT. The others are risk factors, right? So you add up all the points over here, and then if it's high, for example, if you have clinical signs of DVT, if you have a tachycardia, if you have hemoptysis, immobilization, almost assuredly it is most likely pulmonary embolism over there, right? Whereas if you don't have any of these risk factors, if you don't have DVT, if you don't have tachycardia, hemoptysis, then there's a very low probability that the underlying condition is a pulmonary embolism over there, right? So please go over this for yourself to see how pulmonary embolism is diagnosed. We're now going to move on to the obstructive lung disorders, starting with asthma. What is the definition of asthma? Asthma is a chronic inflammatory disorders of the airways that leads to reversible, being the key word here, bronchospasm that causes ultimately airflow obstruction. The pathogenesis of asthma is the hyperresponsiveness of the airway to some sort of endogenous or exogenous stimuli that leads to this reversible airflow obstruction, and thereby limits the amount of air that enters and exits the lungs. The inflamed airways will ultimately, over a period of time, undergo a variety of changes, such as hypertrophy of the smooth muscles and hyperplasia of the mucus-producing goblet cells. Approximately 11% of Canadians, that's quite a bit, do have asthma over there. But fortunately, most children do improve in terms of their clinical manifestations as they progress towards adolescence and beyond. What are the risk factors for the development of asthma? Firstly, a family history of atopy. Atopy is simply a fancy word for allergic conditions. So if there is a family history of atopy, that could include family history of asthma, allergic rhinitis, eczema. That would be one of the risk factors for the development of asthma. Occupational exposure, so we know that the airways become hyperresponsive to some sort of stimulus. That could be because of inhalation, chronic inhalation of dust, chronic inhalation of asbestos, chronic inhalation of any real irritant over that. So the pathophysiology is you have airway obstruction that leads to ventilation perfusion mismatch, that in turn leads to hypoxemia, which causes an increase in the ventilatory rate. As the breathing rate increases, you exhale out more CO2, so PCO2 decreases, pH increases, and that can lead to muscle fatigue because of the hypoxemia. And ultimately, the muscle fatigue leads to a decrease in the ventilatory rate, and that causes an increase in PaCO2 and a decrease in pH. So during the initial stages of asthma attack, you do have hypoxemia, perhaps mild hypoxemia, but because of the increase in the ventilatory rate, you have a decrease in the CO2. It gets omnious, we'll see that's would be classified as respiratory alkalosis. Asthma becomes omnious when it becomes prolonged, and that leading to muscle fatigue, a decrease now in the ventilatory rate, so it goes from hypoventilation to hypoventilation, and now instead of respiratory alkalosis, it swings to respiratory acidosis. That's when it becomes omnious. So what are the clinical manifestations in an acute exacerbation of asthma? You have dyspnea, wheezing, chest tightness, cough, and sputum. Those are the classical clinical manifestation because of the airway hyperresponsiveness, because of the bronchoconstriction. The symptoms of asthma are usually worse at night or in the early morning hours, and usually gets better as the day progresses over there. So what are the red flags for asthma? It's when severe tachypnea and tachycardia develops. So now the acute exacerbation hasn't abated, perhaps the inhalers haven't started working properly, or for whatever reason, now the acute exacerbation of asthma hasn't resolved itself. Consequently, respiratory muscle fatigue sets in, there's diminished respiratory effort, and now hypoxemia, resulting in cyanosis, as well as hypocapnia develops over there. So the client or patient becomes so exhausted from the work of breathing, so exhausted that the respiratory muscle fatigue sets in, and consequently CO2 builds up, and as CO2 builds up, hypocapnic respiratory failure as well as a decreased level of consciousness can now develop. As CO2 builds up, it affects neurological functioning, confusion, anxiety, and a decreased level of consciousness all the way to coma can develop. All that is because of the diminished respiratory muscle effort. Let's move on to discuss COPD, which is a very common lung disorder. COPD is defined as the progressive, being the key word, and irreversible condition of the lung characterized by chronic obstruction to airflow, with many patients having periodic exacerbation. That in turn leads to gas trapping, lung hyperinflation due to emphysema typically, and in the end stages, weight loss due to the increased work of breathing. Spirometry is required for a definitive diagnosis, whereby the FEV1 over FEC ratio, forced expiratory volume in 1 second over forced vital capacity, is less than 0.7. The two most common phenotypes of COPD are chronic bronchitis and emphysema, but please note that they usually coexist in every client and patient to variable degrees. That is why the term COPD was developed, because it really doesn't matter whether it's chronic bronchitis or emphysema, the treatment's exactly the same. In COPD, because it is a progressive disease, you have a gradual decline in the FEV, or forced expiratory volume, in 1 second over time. The problem being with that, each exacerbation causes a greater decline in FEV1. Even if there were no exacerbation, FEV1 would decline over time. As you age, FEV1 declines over time, but individuals with COPD have a greater decrease in the FEV1, and it becomes even worse with each exacerbation. Consequently, exacerbations should be promptly treated and minimized. Let's look at the clinical and pathological features of COPD by comparing and contrasting chronic bronchitis with emphysema. Chronic bronchitis is defined clinically. Here's the definition: a productive cough on most days for at least 3 consecutive months in 2 successive years. A pretty tight definition. On the other hand, emphysema can only be diagnosed definitively after death, post-mortem. Post-mortem, you'll see dilation and destruction of the air spaces distal to the terminal bronchiole without obvious fibrosis. So this is not idiopathic pulmonary fibrosis. This is destruction of the alveoli distal to the terminal bronchiole. Let's compare and contrast the other features as well. So in the case of chronic bronchitis, both of these are obstructive lung disorders, but in the case of chronic bronchitis, the obstruction is mostly due to the narrowing of the airway lumen caused by thickening of the mucosa, as well as excessive mucosal production. What happens in the airways, and this is the morphological changes that you see under a microscope, for example, you have an increase in the number of globulate cells, you have fibrosis ultimately of the bronchioles as they get overworked, so to speak, and loss of tethering to the destruction of the alveoli walls. In the case of emphysema, because of the destruction of the alveoli, you have increased blebs that are formed. These are big air pockets, and consequently you have a decrease in the elastic recoil of the lung parenchyma. You have decreased compliance. This prevents or reduces expiratory driving pressure that ultimately causes the airway collapse, which is the obstruction and trapping of the air in the lungs. Consequently, a very prominent feature of emphysema is lung hyperinflation over there. So here's what it looks like in emphysema. Here's normal alveoli. You can see the alveoli walls. Here's it in emphysema, where you have destruction of the alveoli walls and formation of these big pockets of air that are referred to as blebs over there. That in turn is going to affect the expiratory pressure. Air is not driven out of the lungs as efficiently as it is in a normal individual. Consequently, more air is trapped inside the lungs, resulting in hyperinflation. On the other hand, in emphysema, although it's not shown over here, not emphysema, in chronic bronchitis, you have increased mucus production and hyperplasia of the smooth muscle and of the goblet cells, and that causes all the buildup of mucus in the lining smaller airways, and that causes the obstruction. Let's take a step back and try to explain what causes the destruction of these alveoli walls in emphysema, for example. So the main etiology for COPD is, yes, cigarette smoke, and that in turn causes activation of the immune system, because there are thousands of nasty chemicals in cigarette smoke, most of which have not been identified, and that causes activation of the immune system, especially of the macrophages, resulting in inflammation. So inflammation causes activation of other immune cells, such as the neutrophils, and that in turn, along with the inflammation, causes activation of these proteases like the elastases and MMPs, metalloproteins. That causes destruction of the airways over here. In a normal individual, yes, these proteases are present over there, but they are counterbalanced by the anti-proteolytic enzymes such as the alpha-1 antitrypsin. So in a normal individual, you have this inactivation of these proteases over there by the anti-proteolytic enzymes, as mentioned. However, when you smoke, the cigarette smoke has all these various oxygen radical species over there, and they cause inactivation of the anti-proteolytic enzymes. They cause inactivation of alpha-1 antitrypsin, and now the proteases such as the elastases and MMPs can run amok, thereby causing destruction of the alveoli wall. Here's another table that compares and contrasts the clinical features of or clinical manifestations of chronic bronchitis and emphysema. Please don't use these very pejorative terms. So previously, chronic bronchitis sufferers, individuals with chronic bronchitis predominantly would be called blue bloaters, and if they were predominantly had features of emphysema, they would be called pink puffers. Don't do that. Instead, just focus upon what the clinical manifestations are, and that will help you determine whether a particular patient has predominantly features of chronic bronchitis or predominantly features of emphysema. So the main features of clinical manifestations of chronic bronchitis is this chronic productive cough and purulent sputum. The purulent sputum especially occurs in periods of the acute exacerbation. Other clinical manifestations of chronic bronchitis is cyanosis, which is secondary to the hypoxemia. So you have a diffusion defect over here, peripheral edema that occurs from right-sided heart failure, which is called pulmonary. That occurs because of increase in the pressure in the lungs, causing increased workload on the right side of the heart, on the right ventricle, resulting in copulmonary, and that in turn causes right-sided heart failure. And we know for right-sided heart failure, it causes backup of blood in the venous system, systemic venous system, resulting in peripheral edema. Other clinical manifestations include crackles and wheezes because of the mucus buildup over here, prolonged expiration, that's kind of the definition of the obstructive lung disorder, and clients with chronic bronchitis are frequently obese, that's a observation over there. For emphysema, you have dyspnea, more dyspnea compared to chronic bronchitis, although there is a minimal cough. So cough is more predominant in chronic bronchitis, whereas dyspnea is more predominant in emphysema. Tachypnea and the decreased exercise tolerance also there. At least initially, In emphysema, the skin is pink, so it's well perfused and oxygenated, unlike in chronic bronchitis over there. However, other characteristic features of emphysema is this pursed lip breathing. Remember, in emphysema, there is a reduced driving pressure in the lungs. Consequently, in order to increase the driving pressure of the lung and to prevent the collapse of the alveoli, you purse your lips. That increases the back pressure, and in turn that prevents the alveoli from collapsing over there, because you have destroyed the alveoli wall, reduced driving pressure, so you want to prevent it from collapsing. It's much like a balloon. It's very difficult to initially blow up the balloon. Once it's blown up, it's a lot easier. So what you want to prevent is a complete collapse of the alveoli, and that is accomplished by this pursed lip breathing. Because you want to prevent the collapse of the alveoli, you have also increased use of the accessory muscles, such as the intercostal muscles. Consequently, there is increased work of breathing itself. Normally, breathing does not require large amounts of calories to be expended. We don't think about our breathing, but now when you have to think about breathing, whether you have to work at breathing, you're going to be using a lot of calories. Consequently, individuals with predominantly emphysema features will appear to be more cachectic because they've used and have to use a lot of calories just for the work of breathing. We already mentioned the hyperinflation of the lungs. As the alveoli break down, the walls of the alveoli, more air gets trapped. That results in hyperinflation. I'm not sure why I'm constantly saying hyperinflammation. Hyperinflation, and that in turn causes the phenotype of emphysema, whereby the individuals have a barrel chest appearance. Also, the hyperinflation causes hyperresonant percussion, as well as a decreased breath sound. So the air that is in the lung, yes, is there, it's not moving in and out. So in fact, there's decreased breath sounds and decreased movement of the diaphragm as well. So on a chest x-ray for individuals with predominantly emphysema, you will see the hyperinflation of the lungs. There is an increase in the anterior-posterior diameter. As the lungs inflate more and more, the diaphragm flattens out, so you have a flat hemidiaphragms over here. In the case of chronic bronchitis, you don't typically see the features of hyperinflation of the lungs. So chest x-ray, AP diameter is usually normal, although the increased bronchovascular markings as the as the blood pressure in the lungs increases over there, you see those bronchovascular markings as well. And lastly, you might also see evidence of cor pulmonale, the right ventricular hypertrophy, especially in the end stages. These two x-rays illustrate the hyperinflation of the lung for clients and patients with predominant emphysema. Here you can see the increase in the volumes of the lungs caused by the air trapping. You can see the flattening of the diaphragm. This is in the AP view, anterior posterior view, and here in the lateral view you can see the same thing. The diaphragm should be curved this way, it's completely flattened, and you can see the severe hyperinflation. So this particular client has predominantly emphysema as a phenotype for COPD. What's the treatment for COPD, as well as the nursing intervention? Clearly, the main etiology of COPD is smoking, and hence smoking cessation should be offered as health education to these clients and patients. Vaccinations against pneumococcal pneumonia in order to prevent exacerbation of the COPD, and if necessary, home oxygen when warranted. Home oxygen therapy is frequently administered in order to prevent cor pulmonale from developing, and it does decrease mortality risk if used throughout the day. Home oxygen therapy is indicated if the PaO2 is less than 55 millimeters of mercury, or if there is evidence of cor pulmonale or polycythemia if the PaO2 is between 56 and 59 millimeters of mercury. In addition, the treatment for COPD in terms of drug therapy are the bronchodilators such as salbutamol, that's a SABA, and the LABA would be salmeterol, as well as corticosteroids to tampen down the immune response and inflammation. Just a little bit about the spirometry in terms of diagnosis of COPD. So here's a normal spirometry over there. And here's the spirometry in a patient with COPD. You can see the decreased FEV1, the decreased FVC, or forced vital capacity, and it's really about the ratio of FEV1 to FVC. It's less than 0.7. Also, you can see the increased residual volume over here due to air trapping. That is predominant in emphysema. We saw the chest x-ray is a really good way of diagnosing emphysema via the hyperinflation of the lungs. Lastly, just to show you the pattern of decline in the FEV1, for a normal individual who's never smoked, you can see here it does decline as you age. That is a natural progression over here. However, if you smoke, you can see the significantly quicker decline over here. Disability, beyond this line, disability occurs. So if you do smoke, you can see on average you really shouldn't be disabled if you have never smoked, at least in terms of lung function. If you do smoke, you can see, I don't know, let's just say this is 70 years of age or so, you become disabled and dead shortly thereafter. However, if you stopped at, actually this is 65, if you stopped at age 65, now you prevent further deterioration in terms of lung functioning, in terms of the FEV1 values over here, and you can see this line is more or less parallel to this line. So yes, it does decline, but that's because of age, and it's not an accelerated decline because of smoking. If you stop smoking at an earlier stage, say at 45 over here, you can see the line now just mimics, was more or less parallel to the line for aging, the decline due to aging, and you can clearly see how many extra years you've had of a more productive life that is not affected by disability over here. That's many decades over here, right? So it doesn't really matter, but it doesn't really matter what age you stop smoking. The key thing is to stop smoking, right? Even at age 65, stopping smoking will, if this is death, you can see you bought yourself a couple of years, right? That's significant over here. And clearly, if you stop smoking at a much earlier stage, it's many decades of a much more productive and a life that is hopefully free from disability. Let's move on to cystic fibrosis. The etiology of cystic fibrosis is that it is an autosomal recessive disorder in the particular gene that codes for the CFTR protein. The CFTR protein is a gene that is involved in chloride transport. It helps to dilute down the mucus. If there's a defect in that, it prevents osmosis from occurring properly. In order to dilute the mucus becomes a lot thicker. So the pathogenesis in cystic fibrosis is that you have a chloride transport dysfunction in the CFTR protein, and now the secretions from the various exocrine glands become a lot thicker because they're not diluted down with water. So the secretions in the lungs, the pancreas, and the reproductive tract become a lot thicker, and that can cause a blockage of the secretory ducts and further damage to the secretory ducts in the lungs. That leads to the characteristic pulmonary manifestations resulting in severe lung disease. It's mainly due to the recurrent lung infections. So all that thickened mucus over there is just a good breeding ground for a lot of pathogenic bacteria such as S. aureus, H. influenza, and so forth. And that only leads to these recurrent lung infections, which damages the lung, leading to severe lung disease. In addition, cystic fibrosis doesn't just affect the lungs, it can affect many other organ systems that have the secretory ducts and exocrine function. So pancreatic insufficiency is also very common, and individuals with advanced cystic fibrosis will require dietary supplementation, will require supplementation of all the dietary enzymes in order to maintain proper nutrition. Let's move on to pulmonary edema. In terms of pulmonary edema, if it is a cardiogenic cause, it's a little bit different from if it has a non-cardiogenic cause. So we've seen previously in heart failure that for left-sided heart failure, the backward effects are that blood gets backed up in the lung, increasing the hydrostatic pressure, resulting in pulmonary edema. So heart failure is a cardiogenic cause for pulmonary edema. There are non-cardiogenic causes of pulmonary edema, for example, in acute respiratory distress syndrome, whereby the pulmonary capillaries become a lot more permeable, and that leads to pulmonary edema. In fact, pulmonary edema is a defining feature of ARDS. What are the clinical manifestations of pulmonary edema, regardless of whether it's cardiogenic or non-cardiogenic in nature? Dyspnea, crackles, and in the chest x-ray, you can actually see the fluid buildup within the lungs. Atelectasis is a partial or complete collapse of the lungs, and that obviously causes a reduction in lung volume. What are the features or risk factors for atelectasis? COPD, smoking, obesity. As you age, your risk of developing atelectasis increases after surgery as well. Clinical manifestations of a partial or complete collapse of the lung include tachypnea, tachycardia as a compensatory response, crackles, decreased breath sounds as the lungs deflate, more bronchial breathing, and perhaps if it's post-op atelectasis, a low-grade fever as well. The post-op prophylaxis in order to prevent the development or reduce the incidence of atelectasis includes incentive spirometry and various deep breathing exercises that the nurse should provide in terms of health education to prevent the onset of atelectasis. Moving along to acute respiratory distress syndrome, or ARDS. ARDS is a clinical syndrome characterized by severe respiratory distress, hypoxemia, and non-cardiogenic pulmonary edema. So it has to have those features of, yes, respiratory distress, hypoxemia, and non-cardiogenic pulmonary edema. So the criteria is that an acute onset within about a week of a defined event, such as sepsis or severe pneumonia. In ARDS, the chest X-ray should show bilateral opacities that are consistent with pulmonary edema. Without pulmonary edema, it cannot be characterized as ARDS. And remember, pulmonary edema is also pretty common with left-sided heart failure. So if the client also has left-sided heart failure, either the pulmonary edema has to be more prevalent or it has become worse, because clients with left-sided heart failure will be anticipated to have pulmonary edema. So it's pulmonary edema not really caused by heart failure, pulmonary edema as well as hypoxemia and severe respiratory distress in the context of a very severe event such as sepsis or pneumonia. That would be ARDS. The etiology, as mentioned, is the direct lung injury. So it could be because of aspiration, it could be because of pneumonia, smoke inhalation, pulmonary embolism, reperfusion injury, or indirect lung injury because of sepsis, shock, trauma. Regardless of what the etiology is, a very severe event or stimulus can lead to acute respiratory distress syndrome. The pathogenesis that we will try to explain in order to see why pulmonary edema, non-cardiogenic pulmonary edema, is a feature is that for ARDS, the main pathogenic mechanism is the disruption of the respiratory membrane. Now you have leaky capillaries, and a lot of fluid gets exudated from these leaky capillaries, resulting in pulmonary edema, which in turn leads to reduced compliance, ventilation perfusion mismatch. Since the ventilation perfusion is mismatched, now you have shunts developing that in turn causes hypoxemia as well as pulmonary hypertension. In the lungs, where areas that are hypoxemic will undergo vasoconstriction. Usually it's the other way around in the rest of the body, but in the lungs, if that area is hypoxemic, there's no point really sending blood to that area because it's not going to get oxygenated. So vasoconstriction occurs, but that in turn promotes pulmonary hypertension. So a vicious cycle develops. For the clinical manifestations in initial phases of ARDS, you have dyspnea, tachypnea, increased work of breathing, and that slowly leads to respiratory fatigue and eventually hypoxemic respiratory failure. We spoke about hypoxemic respiratory failure previously. In the late stages of ARDS, you have dyspnea, tachypnea, that is getting worse, fatigue, and now the hypoxemia is so profound, in other words, you have hypoxemic respiratory failure, that mechanical ventilation is required. The mortality rate is rather high at 30 to 40% due to these non-pulmonary complications such as hemodynamic instability. We're going to switch gears now and talk about infections, starting with the upper respiratory tract infections. So this particular diagram was taken from Public Health Ontario, comparing seasonal influenza, the flu, with a COVID-19 infection versus an RSV infection versus rhinovirus that causes the common cold. So what are the most common symptoms of influenza? There's a sudden onset of fever, usually a high fever, cough, chills, headaches, fatigue, myalgias, runny nose, and body aches. For SARS-CoV-2 or COVID-19, you can see it's pretty similar to the flu, but there are other more particular symptoms, more characteristic symptoms, including the loss of taste and smell, and perhaps increased incidence of gastrointestinal symptoms such as nausea, vomiting, and diarrhea. RSV, again, similar to the flu, The bottom line being that it's really hard to tell which particular upper respiratory tract infection this is outside of testing. There are tests available, although now not commonly distributed, for rapid tests, antigen tests for SARS-CoV-2, for COVID-19. They are for influenza and RSV, but that's just not very common. If you compare the rhinovirus, a common cold, it's usually a runny nose, sneezing, coughing, sore throat, much lower incidence of muscle pain, fatigue, and so forth. But it's really hard, the bottom line is, to distinguish what virus it is just based upon the clinical manifestations. So let's look at the complications as well. For the flu, the main complication is pneumonia, and that depends upon the underlying comorbidities as well, and it can progress to become far more severe, including sepsis and death over there. For COVID-19, it's pretty similar as well, although the common refrain is you can't spell COVID without CVD. It is about the cardiovascular complications as well, especially the incidence of blood clots that can occur anywhere in the body, in the lungs for PE, for heart for an MI, and so forth, as well as this multi-system inflammatory syndrome as well, so-called MIS. For RSV mainly affects the very young and the elderly. It's much more severe. In adults, it usually has a much more benign course. But for RSV, the complications are pneumonia, bronchiolitis, and death. And usually for rhinovirus, outside of infants, there are not severe complications. As we alluded to, what are the main risk groups for these various viruses? For the upper respiratory tract infections, for influenza, young children, older adults, adults who are immunocompromised, pregnant women, those would be the main risk groups for the development of the complications that we discussed. For COVID-19, again, it's older adults and those with comorbidities, including being immunocompromised. For RSV, it's especially young infants, less than 2 years of age, as well as the elderly and those that are immunocompromised. Again, you can see it's pretty similar for all three. And rhinovirus, it's young children and those that are immunocompromised, less so the older adults. Let's now focus on lower respiratory tract infections, specifically pneumonia. The definition of pneumonia is infection of the lung parenchyma or the lung tissue. In terms of the etiology and risk factors, we'll start off with the risk factors. Those that have these risk factors are more at risk of developing pneumonia if they have impaired lung defenses, such as a poor cough reflex or a gag reflex. That might be due to illness or drug-induced. If they have impaired mucociliary transport, for example, in cystic fibrosis. If they are immunosuppressed because they are on corticosteroid drugs or chemotherapy or HIV/AIDS, then they have an increased risk of developing pneumonia. In addition, if they have an increased risk of aspiration, for example, if they have impaired swallowing mechanism, such as when they have a decreased level of consciousness or dysphagia, then they are also at risk of developing pneumonia. In terms of the etiology, the most common causative microorganisms for pneumonia is Streptococcus pneumonia for community-acquired pneumonia or CAP, and enteric gram-negative bacteria, for example, E. coli for nosocomial pneumonia, or pneumonia that is contracted in the hospital setting, for example. Here's just a few of the common organisms in pneumonia. I'm not going to go through this. You'll see this in microbiology again, but for community-acquired pneumonia, it's most commonly Streptococcus pneumonia. For nosocomial pneumonia, it's this enteric gram-negative bacteria, for example, E. coli, O.S. aureus, including MSRA, and then you can read for the other ones as well. In terms of the clinical manifestations of pneumonia, they include a productive cough, although sometimes it's not productive, a fever, pleuritic chest pain, dyspnea, tachypnea, tachycardia. Those would be compensatory responses. But the problem with pneumonia is that in the elderly, it often presents atypically. Oftentimes, an altered level of consciousness is the only sign. In terms of other clinical manifestations, from the chest x-ray, there should be evidence of consolidation, as well as when the assessment is done, there should be dullness to percussion, more bronchial breath sounds, as well as crackles. Lastly, the complications of pneumonia include ARDS, lung abscesses, inflammation of the pleura or pleuritis, with or without hemorrhage. In terms of the investigations that should be done, they include pulse oximetry to assess the severity of pneumonia, to assess for the SpO2, arterial blood gas values for PO2 and PCO2, as well as pH, the culture and sensitivity to identify the causative microorganisms, and a chest x-ray to determine the severity of the pneumonia, including how much consolidation there is, as well as what percentage of the lung is affected. Is it lobar pneumonia? Is it segmental pneumonia, etc., or interstitial pneumonia? In terms of the interventions, always support the ABCs, oxygen therapy if required, IV fluids for rehydration, salbutamol as a bronchodilator, as well as antibiotics to treat the causative microorganisms. But that's where CNS is required in order to see what the causative microorganism is and is it sensitive to the particular antibiotic that is planning to be administered. Here are just a few chest x-rays, so you can see lobar pneumonia. You can see the consolidation in the middle lobe of the right lung of here. In this case, it's bronchopneumonia, more towards where the bronchi are entering the lungs of here. And this is interstitial pneumonia, where it affects pretty much the entire lungs, in this case, bilateral. We're going to come back to upper respiratory tract infection. Probably should have done this before pneumonia. The only one that we're going to focus upon is croup, that affects young children from 6 months to 4 years of age. You can see the prodrome is the flu-like illness. It takes several days before the acute period develops, usually a low-grade fever. In terms of the chest x-ray on the radiography, you'll see the steeple sign. This is the steeple-church signs, whereby the trachea narrows down into a steeple-like position, and that accounts for the fact that you have this very strong stridor developing. The etiology is a parainfluenza virus, and yes, the hallmark clinical manifestation of croup is the seal-like barking cough. The last lower respiratory tract infection that we'll do is tuberculosis or TB. The etiology of TB is aerosolized inhalation of Mycobacterium tuberculosis, which is a very slow-growing aerobe. Its doubling time is 18 hours. Compare that to several minutes in the case of other bacteria. But the problem with Mycobacterium tuberculosis is that it can evade the innate defenses of our immune system, thereby surviving and replicating in macrophages. The macrophages are the host cell of this Mycobacterium tuberculosis. That's what the bacteria attacks. It turns out that nearly 1/3 of the world's population is already infected with TB, but fortunately most individuals are able to suppress the replication of the TB, and they land up with what's known as latent TB. And we'll go through that. So in the case, if you inhale the Mycobacterium tuberculosis, especially in Asia, then the bacteria gets deposited in the lungs, and one of the following outcomes can occur. The immune system, especially if you're otherwise healthy, will immediately clear the pathogen and you're home free. Or the virus does replicate itself, but the immune system suppresses it enough such that it restricts it to certain areas of the body, but it doesn't cause any clinical manifestation. That's called latent tuberculosis, which is an asymptomatic infection that is contained by the host's immune defenses. This represents 90% of the infected people all throughout the world. And remember, 1/3 of the world's population is infected. That's more than a billion and a half people. Primary tuberculosis, on the other hand, is when the disease becomes symptomatic, and it's what's referred to as the active disease. This only represents 5% of infected people, but that's still a very large number. If 1.5 billion people have been infected with tuberculosis, 90%, let's go with 1.3 billion, have latent TB, then, 5% of 1.5, if I'm doing my math correctly, is 750 million people. That's still a lot of infected individuals who have active tuberculosis. And we'll look at the clinical manifestation shortly. Secondary tuberculosis is when you have symptomatic reactivation of a previously dormant tuberculosis. So by far and away, most people have latent tuberculosis, and unfortunately, 5% of that, although I think that's on the high end, will develop reactivation of the Mycobacterium tuberculosis bacteria and then develop primary tuberculosis. If you've been infected with Mycobacterium tuberculosis and develop latent tuberculosis, if you go 1 or 2 years after being infected, in many cases you wouldn't know you've been infected, but if primary TB doesn't develop within the first year or two of infection, then you're usually fine. It means that the immune system has successfully suppressed it. It hasn't cleared it, but suppressed it. And primary tuberculosis is unlikely to develop. Those who do develop secondary tuberculosis develop it within the first year or two of the initial infection. What are the risk factors for the infection with the Mycobacterium tuberculosis bacteria? Travel to a region that has endemic TB, which is pretty much the entire world, especially the Eastern Hemisphere, Asia, Latin America, Sub-Saharan Africa, Eastern Europe over there. So that's a large swath of the world that is infected, at least with latent tuberculosis over there. If you have personal occupational contact, for example, as a nurse, then yes, you also have a risk factor for contracting tuberculosis. Individuals living in very crowded conditions, for example, those that are unhoused and now living in shelters, or individuals with low socioeconomic status, that's all surrogates for individuals experiencing extreme poverty and are unhoused. Also, IV drug users have a greater risk factor of developing tuberculosis. And lastly, those that are immunocompromised, especially if you have active HIV/AIDS, and then one of the key diagnostic criteria for HIV/AIDS is an opportunistic infection like tuberculosis. So if you're immunocompromised, it's much easier to develop primary tuberculosis. Also, if you're immunosuppressed, so if you have another autoimmune disease and you're taking immunosuppressive drugs, such as the corticosteroids, you have an increased risk of developing tuberculosis. What are the clinical manifestations of tuberculosis or a primary or secondary infection or reactivation? Well, they are constitutional symptoms. That's why tuberculosis used to be called consumption, because it literally consumes you from the inside out. So the constitutional symptoms include severe fatigue, anorexia, night sweats, and yes, weight loss, whereby it consumes you. But we most associate tuberculosis with the pulmonary manifestations. That includes a chronic productive cough with or without hemoptysis, or coughing up blood, chest pain, lung consolidation, and usually painless lymphadenopathy. But tuberculosis actually can spread through many other organ systems and not just the lungs. That's what we call extrapulmonary tuberculosis, and it can infect any organ system really. So it can affect the outer covering of the heart, leading to pericarditis, the coverings of the brain, leading to meningitis, the covering of the bone, leading to osteomyelitis. It can affect the adrenal glands, leading to Addison's disease, and so forth. That brings us to the end of this lesson on the pulmonary disorders. Please remember to learn the pathophysiology of all the diseases, conditions that we've discussed, especially the etiology, the modifiable risk factors. The pathogenesis only focus upon very briefly, but most importantly focus upon the clinical manifestations. You should also note that you will only be assessed upon the diseases, disorders, or conditions that are listed in the learning outcomes for Unit 2, which can be found in the syllabus. Please contact me or your instructor for your course if you require any further clarification or assistance with the content of this Unit 2 on the pulmonary disorders. Our next lesson is going to be on the neurological disorders. That's going to be Unit 3. See you then. Thanks. Bye.